took advantage. And forced them into grand rounds. So thank you, John. So he went to the University of Maryland and majored in math, and then went to Hopkins for med school and residency, and then to my alma mater, did his pediatric neurosurgery at UAB, Children's, Alabama. I want to start by saying, you know, as some of you know, I dedicated this stage of my career to improving shunt issues, mainly because for many years it was half my practice and half of many pediatric neurosurgeons, if not most, practices, and it's the biggest source of morbidity that we have. And there is a growing number of people, John included, now that have the same thought process. You know, in the past, we, as some of my more senior partners remember, we get patients with shunt malfunction, repair it, send them home, hope they don't come back, and they almost always come back. In fact, 40% of shunts fail within a year of placing. We changed. Now, when a shunt malfunction comes in, I repair it, and then I ask myself, how do I make it so that they don't have to come back with another malfunction? And we've been highly successful at this, and the main reason for this is understanding pathophysiology. Until you understand what makes them break, you're not going to be able to fix them, no matter how many programmable valves, how many new technologies that you introduce. And so to understand the pathophysiology, there's hydrodynamics, there's morphometrics, and this is, I think, why John is interested in this, because of his math background. So thanks to Mark Kramer and Joyce, and then in neurology, Dave Shu and Chris Lucio and Josh Meadow here, we started a team that looked at this, and we're convinced that chronic shunt overdrainage is the primary driver of shunt obstructions, hands down. And now it's being shown at laboratories elsewhere. But it's more than this. There's hydrodynamics, there's morphometrics, and John's interest is morphometrics starting with the skull, because as you know, you shunt patients early in life, their skull doesn't grow. It's not just the brain and the ventricles. So John, thank you for coming. I look forward to this and look forward to the research.
Awesome. Yeah. Thank you so much. Yeah, I wanted to just say thank you very much, Dr. Iskandar, and everybody for inviting me to be here. I'm really grateful for the opportunity. And I really share the same passion that Dr. Iskandar was talking about regarding the potential perils of cerebral spinal fluid overdrainage. Obviously, shunting does a fantastic job of mitigating morbidity. But as we're understanding more about cerebrospinal fluid dynamics and the potential, well, adverse sequela of overdrainage, it's caused me at least to approach treatment of patients with hydrocephalus in a little bit different fashion. So, the talk today is shunt-related cerebrospinal fluid overdrainage during treatment of infant hydrocephalus when supra-physiologic becomes super-bad. Not let me advance. Oh, all right, I'll just advance. That's fine. All right, so there are no relevant disclosures. No conflict of interest, no financial disclosures. But as Dr. Iskandar mentioned, the irrelevant disclosures is I'm very fierce and avid Baltimore, Maryland fan. So I apologize to everybody in the crowd. I don't like these teams, but I'm a big Ravens, Maryland, and we're talk about that later. This is the professional slide that you guys sent me, so thank you. No relevant financial relationships, and I won't discuss any community. The learning objectives by the end of this presentation, hopefully be able to describe the magnitude of pediatric hydrocephalus nationally and internationally, explain some of the risks of supra-physiologic CSF version development, particularly during the infant toddler years, and then maybe interpret clinical and radiographic features early that may suggest shunt-related cerebrospinal fluid overdrainage. And then I kind of put asterisks by this one because this is something that we hope to do in the future, is develop methods or strategies to mitigate risks of shunt-related CSF overdrainage. This is just an outline First, we'll start with a background and overview of pediatric hydrocephalus, a couple of brief slides of the epidemiology, some options for CSF diversion, which should be no surprise to the crowd. And then I'll focus a little bit more on cranial growth, which can be helpful for some, for some boards prep also. So sorry, it's after your board exam, but tuck it away for next year. And then we'll kind of go into the specifics of calculated schools on research lab. And some of the early findings we had over nationwide children's for post-shunt acquired creative synostosis. It's mostly single institutional data. And then next steps, created a quality improvement project out of it. I'll just give you a couple slides out of that, hopefully as maybe a catalyst to spark interest for quality improvement for residents in the crowd. And then talk about our early efforts to achieve grant funding for this. So just to review some of the epidemiology, Dr. Eskin mentioned, it's one of the main pathologies we deal with in neurosurgery, particularly pediatric neurosurgery. The incidence of hydrocephalus, pediatric hydrocephalus, about 400,000 cases per year worldwide. There is some geographic variability, and about half of those cases are accounted for in sub-Saharan Africa. The annual incidence total congenital hydrocephalus is about 81 per 100,000, and there is variation based upon income, with lower and middle income countries having a higher incidence, about 100 to 600 treated cases per year. The global prevalence is about 88 per 100,000. It's about one memorable figure. And again, there's variation between different demographics, Africa being almost double the rate in America. The most common etiologies of hydrocephalus in the pediatric population are myelomeningocele, post-hemorrhagic hydrocephalus, congenital aqueductal stenosis, and especially, internationally, post-infectious. We have limited methods of treating hydrocephalus. The primary method of treating hydrocephalus is with shunt insertion. That technology was designed in the 1950s. The Holter valve with elastic tubing was patented in 1956. There have been improvements since 1956 in the design, but overall it's a similar theme, and there have just been minor adjustments into valve settings, trying to limit the amount of drainage at certain times throughout the day and certain physiologic contexts. The other option is endoscopic ventriculostomy with or without port plexus cauterization. Port plexus cauterization is typically reserved for infants of age 0 to 12 months, even the age. That is backed by research mostly by Dr. Worf, and has been shown outside of the hospital. Unfortunately, not all patients are great candidates for endoscopic ventriculostomy with or without port plexus cauterization. We're looking at that now through the HCRN. There's the ST trial, which is endoscopic versus shunt for treatment of hydrocephalus in infants. The NIH-funded study, which for the most part takes all comers 0 to 24 months of age with hydrocephalus. One of the exclusion criteria is prematurity and intervention bone hemorrhage related to prematurity, just because we know from experience patients with post-hemorrhagic hydrocephalus have unacceptably low success rates following ETV. But that trial right now is trying to identify whether or not ETV with CPC is a legitimate treatment alternative to CSF shunting, and hopefully identify patient subpopulations. But currently, we all understand that ETV CPC, while great, is not necessarily an effective method for all types of hydrocephalus. So until we have better breakthroughs in research, shunting is still the primary modality of treating hydrocephalus. So as Dr. Eskandar pointed out, it's good, but not great. Shunt failure rates are unacceptably high. 45%, probably the newer literature, within the first 2 years after shunt insertion. Shunt infection, depending upon the study that you read and you trust, about 4 to 17% per procedure. Typically within the first 6 months, the risk really drops off after the 6 to 12 month time period, not impossible. Later shunt infections are typically like a secondary site of infection from some other primary, like if it's an intraperitoneal shunt and the patient has some type of intra-abdominal infection, you could then secondarily seed the shunt hardware. But the primary shunt infection, typically highest rate in the first 6 months. HCRN centers, which I'll refer to the HCRN Hydrocephalus Clinical Research Network a couple of times throughout this talk. It's something I'm very passionate about it. It is a group of academic children's hospitals throughout the U.S. and Canada is really dedicated to improving the diagnosis and management of kids with hydrocephalus. So through protocol development and different antibiotic irrigation and antibiotic-impregnated catheters, combinations have resulted in lower risks of infection, about 5 to 8.8%. I think the most recent published papers were about 5 to 6.5% risk of infection. But unfortunately, the risk of failure for any pediatric patient who undergoes shunt surgery is really high, 60 to 80% over 10 to 12 years. In addition to the perils of shunt failure, when shunts work, but they work too well, it can create a situation of supra-physiologic CSF diversion or CSF overdrainage. And some of the adverse sequelae of CSF overdrainage would include, and I'm sure everyone in the crowd has seen this in scans, extraaxial fluid collections, subdural hematomas, ventricular collapse, and even slit ventricle syndrome, which can be very challenging to manage, low pressure headaches, microcephaly, cranial deformity, and then post-shunting acquired cranial synostosis. In the infant and toddler population, I've been much more interested and focused on the latter two. So just as kind of a brief overview of cranial growth, this is going to kind of demonstrate why it's important to focus on the adverse sequelae of CSF overdrainage in the toddler population. So the neurocranium is composed of the chondrocranium, which is the cranial base. It originates from the periaxial mesoderm and undergoes endochondral ossification, as opposed to the cranial vault, which undergoes membranous ossification. I just include that because that might be important for boards. And then those cranial vault bones are then kind of connected at their junction sites with cranial sutures, which are basically bands of fibrous connective tissue, which provide for sites of bone deposition and then prevent premature fusion of those calvarial segments. The cranial bones are enveloped by a layer above and a layer below. The layer below is, of course, the dura mater, and the layer above is the periosteum. Both of them provide osteogenic growth and signaling factors, and particularly osteoclasts, which are present on the endocranial surface, ectocranial surface, and through kind of a complex interplay, they allow for continued outward growth of the bone as the intracranial structures expand, the cerebrum and cerebellum. And so there's a parallel growth that occurs between the intracranial structures, primarily the brain and the dura, and then the cranial structures themselves. We know that rapidly expanding cerebral hemispheres and the resulting tension of the dura mater is a critical factor for cranial vault growth. There's a really good, insightful paper by Frasanito in 2019, which discusses the growth of the neurocranium if you're interested. It's a good literature review and talks about some of the pathophysiology and mainly focuses on the periosteum, the dura, and then the cranial sutures. And this is just an example of if there's no outward force, then the cranial bones become kind of opposed at the cranial suture, and not allowing for the continued growth of the calvarium. So this is important during the infant and toddler years because there's the most rapid and accelerated cerebral and cranial growth during ages 0 to 2 years, such that at birth, the cranial volume estimates about 25% of the adult volume, but by 6 months, it's already achieved approximately 50% of the adult volume. By 12 months, surprisingly, about 2/3 of the adult volume. And by 7 to 8 years of life, the cranium has already achieved about 90% of adult volume. So beyond 8 to 10 years of life, there's really not pretty significant acceleration of cranial growth after 7 to 10 years of life. And one of the techniques that we use in clinic, as I'm sure you're familiar with if you've been in pediatric nursing, the junior residents, is that the occipitofrontal circumference, the head circumference, nicely parallels calvarial growth. So we can use that to track patients. So, I became interested in this topic when we had some changes in our group, and I ended up taking the lead on craniofacial surgery, and so we were managing these patients who had cranial synostosis. And then, I started paying attention to some of the patients who became who underwent shunt insertion during infants and toddler years and realized, like, yeah, it's great, their ventricles look collapsed, fantastic, their head circumference. Then I started looking at their head circumference. I'm like, is it really supposed to do that? Is it supposed to peak but then plummet and then plateau? And I just intuitively, you look at that and you're like, that can't be right, that can't be good. And then you're talking with some of these families and they're like, yeah, their Hydrocephalus is treated well and this is great, but like my kid's head is really small. Is that going to change? Is my child going to be relegated to a life of microcephaly, for basically all their adult years? I didn't really have a great answer for that. And then I started looking at some of these head CTs, and I'm like, and that's something I didn't really pay attention to in residency. It's all about getting those ventricles down. That's what fortunately, I think for here, we're trying to get those ventricles down. It's last. We don't want ventricular megaly. I'm starting to realize, I think a lot of people who do Hydrocephalus start to realize that ventricular megaly is not necessarily a bad thing, and there's some degree of ventricular megaly which ought to be tolerated. As long as the patient's not demonstrating clinical symptoms or signs of elevated pressure. So I started becoming much more interested in the impact of cerebral during the infant and toddler years. And it's mainly because CSF diversion during infant and toddler years occurs during these critical periods of neurocranial growth. And supra-physiologic CSF diversion can, it may alter the forces which are necessary required for outward neurocranial growth. Shunt-related CSF overdrainage, it could predispose already a very vulnerable population to microcephaly, cranial deformity, and then even post-shunt acquired craniosynostosis, which is very, very challenging to treat. So, looking at some of the studies in cerebrospinal fluid production and then cerebrospinal fluid overdrainage, it's been very commonly reported that the rate of CSF production is about 0.3 to 0.4 cc's per minute, right, from many different sources. That calculates out to about 480 cc's per 24 hours, but a range of about 450 cc's per 24 hours. Ultimately, in working with Dr. Iskandar's lab, I would love to just have simple mathematical comparisons about, rates, volumes of drainage versus rates of production. And, my fear is that there's going to be an unwanted discrepancy. So CSF overdrainage due to pressure pulsations, research, especially coming from Dr. Iskandar's lab, it has shown that CSF overdrainage can result from pressure pulsations, despite our best attempts with shunt valve designs. There can be gravity-dependent overdrainage, which is like siphoning, like the patient transfers from the horizontal position to the vertical position. There can be just rhythmic pulse pressures, based upon the cardiac cycle, and then probably most prominently Valsalva maneuvers, which can augment those pulse pressures up to 60 centimeters of water. I had the opportunity to talk with Dr. Iskandar at a previous WNSCNS pediatric meeting, and he told me about research that's being performed here. So I read a couple of the papers, and just a schematic that was published in one of their papers of the pseudoventricular benchtop valve nesting platform, which has shown that differential pressure valves, they do mitigate CSF flow increases. However, we still observe higher CSF flow rates, like gravity-dependent changes, siphoning. Can increase CSF outflow by a factor of 2 to 4, and then intracranial pressure pulsations, particularly with position, such that in the vertical orientation, you can achieve 15 to 16 cc's per hour of CSF rate. Other interesting work that's come out of the lab has shown that overdrainage has a significant impact and role in obstruction. I'm laughing at the back about somebody who did this research, but almost a third, 28% of cases where there was a neuroendoscopy during the time of shunt revision showed that there were overdrainage related to ventricular catheter bands inside the catheter. Chronic CSF and the formation of the penfold band represents a factor of proximal catheter malfunction. So we already know that CSF overdrainage has one particular adverse sequela, which is prompting or creating a shunt obstruction. I'm interested in looking at another potential adverse sequela, which is overdrainage during the toddler years, which can really disrupt minimal cranial. So post-shunt acquired craniosynostosis is a topic that I've become really focused on because it's a little bit easier to identify objectively. saying an abnormal cranial morphometry or some type of cranial distortion is kind of hard to define. But post-shunting acquired craniosynostosis is something you can objectively define on a CT scan, especially in a patient who hasn't had craniosynostosis before. So post-shunting acquired craniosynostosis is early fusion of a cranial suture following CSF shunt insertion, particularly in a patient who has not had the diagnosis of a craniofacial syndrome or any type of evidence craniosynostosis before. It's very challenging to manage. It's very distressing for families. Fortunately, not a large percentage of these patients require surgery, but if they do, it's very challenging because with the shunt in place, as you know, with ongoing cerebrospinal fluid diversion, it's really going to be challenging to make a treatment for craniosynostosis sustainable. It requires frequent surveillance and possible communication. So when I started looking at some of the reported rates of post-shunting acquired craniosynostosis, I realized there's a pretty wide variation. Some of the older estimates from the 1970s were low. It's likely an underreported or underestimated, about 1 to 5%, okay, the 1970s. But it's newer estimates, 2006, 2012, up to about 49%. This was a plastic surgery that I think more routinely acquired head CTs in their surveillance imaging than most pediatric. But they found that a median duration of time to the development of post-shunting acquired craniosynostosis is about 26 months. But nearly half of the patients that were treating with CSF diversion during infant and childhood years developed post-shunting acquired craniosynostosis, which I thought was pretty eye-opening. So we started looking at our own experience with treatments of infants and toddlers with hydrocephalus, and wanted to define what our single institution prevalence of post-shunting acquired craniosynostosis is. So we wanted to investigate the prevalence and characteristics of hydrocephalic infants developing post-shunting acquired craniosynostosis. We were looking at shunt insertion at the age of less than equal to 12 months. And we just started off with just 3 years, 2020 to 2022, we were expanding. We were looking for patients who had at least 6 months of follow-up. And obviously the exclusion criterion was any pre-existing craniosynostosis or craniofacial syndrome. So we mainly wanted to look at frontal occipital horn ratio in terms of imaging findings. As I mentioned, head circumference and orbitofrontal circumference really parallels cranial volume. So, and that's something which is routinely measured in clinic visits. So we wanted to track serial head circumferences. So far from just those 3 years, total sample size of 64 subjects, and we found a prevalence of post-shunting acquired craniosynostosis of about 19%. Okay, so certainly higher than the older estimates in the 1970s, certainly less than some of the reported rates of the 49%. So, and we found that the diagnosis of post-shunting acquired craniosynostosis occurred at about a mean of 15 months, okay, following surgery. But it can occur as early as 3 months, so which is kind of. So we started looking into some of the factors. Some of the thoughts being that, well, if you have a programmable valve, you ought to be able to try to prevent post-shunting acquired craniosynostosis as much as you can. We found that, surprisingly, actually, that the post-shunting acquired craniosynostosis have a higher percentage of having a programmable valve, which means to me it's not necessarily the programmable valve which is the problem. Most likely, the treatment teams realized that patients were probably a setup for developing overdream-related problems. And they probably put in a programmable valve up front to try to mitigate those risks. And either the programmable valve wasn't used kind of aggressively enough, or it just wasn't enough, despite our best attempts. Okay. And mitigating interventions, which would be programmable valve adjustments or even surgery to exchange the valve, occurred in 50% of patients with post-shunting acquired craniosynostosis. It's a low sample size. We're expanding that and extending it, back to 2016. Importantly, we found that collapse position sutures were much more vulnerable to fusion. So the unilateral or bilateral coronal sutures were involved 3/4 of the time. Sagittal suture was involved 2/3 of the time, and the lambdoid sutures were involved, just a very, very minimal amount, just 80%. Disturbingly and unfortunately, 50% of patients experience multi-suture craniosynostosis, which, as you know, is even more challenging to treat and more liable to create a plateau in head circumference and a plateau in cranial volume. So fortunately, again, small sample size, but only 1 out of 12 required cranial vault reconstruction in post-shunt acquired craniosynostosis subjects. But I know that figure is higher now that we've extended it back to, I think, even just extending it back to 2019. We've already identified 2 or 3 subjects during that year who actually required surgery for post-shunt acquired craniosynostosis, mostly mid-future. When we compared the post-septic acquired craniosynostosis for those who did not develop that diagnosis, the hydrocephalus etiologies were similar, and a mean age shunt insertion was similar at about 0.26 years, about 4th of a year, 3 months. And then when looking at their data, our hypothesis was going to be that there was going to be a much more dramatic drop in the front bone ratio in those patients who developed post-shunt acquired craniosynostosis. We had anticipated that excessive CSF drainage and ventricular collapse would be the culprit. Surprisingly, we found a very similar preoperative FOR between the 2 groups. Again, these are small sample sizes, but the mean change in FOR was essentially the same. So it really wasn't the fact that it's not just ventricular collapse. But as expected, we did find that the mean change in head circumference from a preoperative to at least 12 months postoperative was significantly different. As you would expect, the group with post-shunt acquired craniosynostosis had a much more profound drop in the head circumference. So I'm sure you've all seen it, but that peak preoperatively, and then the pretty dramatic decline, and then the plateau phase afterwards, it's a pretty common finding in these patients who end up developing post-shunt acquired craniosynostosis. Now, again, study limitations. This is retrospective, single center, limited time window, small sample size, but we're going to try and improve upon all of that. As I was starting, research in this area, I also became kind of the leader for our quality improvement initiative for our division, and started becoming really interested in QI. And I thought this was actually a perfect topic to look at for QI, because this is a diagnosis which is not that commonly recognized. We don't get CT scans routinely in these patients postoperatively, so it's something that can become easily missed. So we created a QI project to kind of raise awareness and to better diagnose post-shunt acquired craniosynostosis. So we created an educational presentation about it, delivered it to all of our neurosurgical care providers. We've been meeting with our neuroradiologists to try to systematize 2 radiographic measures, quantitative, that can be related to CSF overdrainage. We particularly focused on the prepontine cistern, which is a qualitative measure, and the mammalopontine distance, which is a quantitative measure. Our neuroradiologist strongly feels that those 2 can be indicative of early signs of overdrainage. And then we've created an automated EPIC screening for providers during clinic visits if a patient fits the inclusion criteria and addresses whether or not the care provider has concerns for them potentially developing overdrainage or post-shunt. That's kind of the early term or early goals for our QI project. The global goal is to reduce the percentage of infants and toddlers with shunted hydrocephalus developing post-shunt acquired craniosynostosis at our institution from 19% to less than 15%, which is a 20% relative risk reduction. So it's conservative, but hopefully it'll push us in the right direction. We just, in meeting with our EPIC builders multiple times, we just came to production and now release of our EPIC auto-generated screening tool, which I wanted to create like a non-intrusive window. But when meeting with our neurosurgery faculty, they actually wanted something that was much more obvious, because their fear was they're going to miss it if it's on the side, menu bar. They've obviously embraced this project, which is great. So now when a patient encounter opens, and they kind of walk through the clinic doors, and their encounter is accessible, this will pop up and will automatically address whether or not the care provider would have concerns. So, and then there are recommendations at the end, or the options to either order a low-dose head CT, which is our method of diagnosing it, or even putting in a referral to our plastic surgery craniofacial clinic, or having them seen by me or one of my other colleagues who manages craniofacial. We're also applying for grant funding. We're looking at an intramural grant. Just applied and we got it back with a request for revision. So we feel like that's potentially a good sign. We're investigating the impact of CSF shunting for infant onset hydrocephalus on cranial morphometry. With that project, we wanted to find the prevalence of post-shunting acquired craniosynostosis over a longer time interval, 2016 to 2023. It's 2016 is not arbitrary. It's actually when we all kind of started as a new group at Nationwide Children's, our current complement of pediatric neurosurgeons. So we're going to be looking at the craniometrics. We've identified about 7 or 8 different craniometric measurements, which we're going to be acquiring from all scans. And then really hopefully identifying risk factors for post-shunting acquired craniosynostosis, ultimately creating a predictive model for post-shunting. And then in terms of an extramural grant proposal, this is kind of like a big picture. I want to love to kind of recapitulate the same type of investigation with a larger patient population. One mechanism might be through the HCRN, just because they have obviously a wealth of academic centers, centers outside the HCRN, collaboration, et cetera. The difficulty in working with bigger groups is just this data is not already collected. So it's going to be a lot of additional retrospective review in acquiring these measurements. So obviously grant funding will be necessary for that. So in conclusion, again, this is not a condemnation of CSF shunts do a great job of reducing mortality and morbidity, neurological morbidity in patients with hydrocephalus. There's no question about that. When you look at mortality rates, post-shunting era and pre-shunting era. However, CSF shunt insertion for infant onset hydrocephalus exposes vulnerable children to the risks of overdrainage. And particularly in this talk and research I hope to continue with focuses on microcephaly, cranial deformity, and then post-shunting acquired craniosynostosis. The prevalence of post-shunting acquired craniosynostosis varies widely in the published literature. I think it's somewhere in between. It's definitely not as low as 1 to 5%. I really hope it's not as high as 49%. But our rate of 90%, seems somewhere in the middle. Hopefully this single-site data is contributing to our understanding of CSF overdrainage and post-shunting acquired craniosynostosis. But really, the main focus, moving forward, we need to acquire multi-site data, which can help uncover risk factors and help develop predictive models for post-shunting acquired craniosynostosis, and may influence the way we treat hydrocephalus, during infancy and the toddler years. So these are, the kind of long list of references. And I wanted to say, truly and genuinely, thank you very much for inviting me out here. I really appreciate this opportunity. And please, everyone, we would love it to repay the favor and have you all, visit OSU and our Nationwide Children's Hospital if you'd like to visit. And then here's my contact information. Thank you very much.
Jonathan,
Yes, please.
thank you very much. You're really onto something here, but I want to assure you that you've got a natural history experiment staring you in the face
Yes. Yeah.
that you could use, because the data you're quoting from the 1970s is patently false.
Yes.
As a person who experienced that, I can tell you that that was the end of the era of the VA shunts.
Okay.
And with their respiratory suction, the overdrainage was universal.
Okay.
And the synostosis was grotesque. That's why it wasn't reported. I mean, it really was deforming grotesquely.
Okay.
And it was only in the 80s. So it's a natural history experiment there in your archives where you can see this effect of that. And those are very measurable, et cetera.
Yeah.
It was a nightmare time of shunt care because of that. Not only did the children overdrain and there's a brainstem form, but they became so inflexible to changes that a shunt failure was a fatal event.
Yeah.
It was a CPR event. It wasn't a gradual decline in Johnny's not acting well and vomiting, which is the VP shunts that you can see. This is a profoundly important factor. And I think that by looking at the extremes of types of shunts, you'll quickly be able to.
Yeah, no, it's a good point. And I mean, I think, it would involve, I guess, during the earlier years, where CT scanning was performed more regularly anyway, then yeah, we would just have a good opportunity. I'm hopeful that the CT scans were, I assume they would be done with enough quality to pick up on the cranial, which they should be. That's a good point, though. I could compare kind of decades of treatment and primary modalities. It's a really good point. Yeah.
Yeah, Sean, thank you. I agree with Bob. You're onto something, and it's like for us to have these types of collaborations. I have two questions.
Yeah.
One, in terms of it's probably compared to a denominator of average, head circumference measures, right? Those head circumference sheets are probably based on, 100 kids from Massachusetts from 1950, something like this.
Big kids from
Minnesota, even worse. So the question is, because you're not really trying to predict what this individual head circumference is going to be like.
Sure.
Right? You haven't looked at their parents, see what their head growth is. You haven't looked. So are there predictive models that you can build to try to individually assess where that patient's head circumference is going to be in 6 months or a year, maybe based on parents' head circumference, maybe based on initial growth over the first 3 or 4 weeks before you got shunted, or a couple of months?
Yeah, it's a good point. I mean, I don't know I would love to. I don't know if we're going to have the parent. I don't know if we'll have the parental data on an individual basis. But I mean, a lot of what we compare to are just normative controls. Maybe we could try to find patients who have a similar degree of ventriculomegaly who did not undergo shunt insertion. I mean, we follow, anecdotally, I know we follow a lot of patients with ventriculomegaly. And I'm sure we could identify, different cohorts who have similar FORs at baseline, and then maybe try to track for comparison.
So we're starting a study to look at headaches in patients who were shunted in infancy or had ETB in infancy,
right,
to see what it looks like later. I mean, that's a cohort that could potentially be used for that kind of measurement. Right. But my second question is, we look at ventricles as neurosurgeons. That's where we.
Yeah.
And then you're looking at the skull. We're forgetting what's the brain.
Yeah.
Right. So if the ventricles are tiny and the skull is tiny, what's happening with the brain in between? And in fact, Steve Schiff's work, as you know, has shown that the volume of the brain, in terms of neurocognitive development, depends more on the volume of the brain rather than the volume of the ventricles.
Yeah.
So the question is, are there morphometrics that you can do, that we can do, some mathematical simulation or whatnot to look at not just the skull morphology, but also brain?
Yeah, very much so. Yeah, I mean, I've been meaning to, and I talked with Dr. Schiff. My goal is to try to work a collaboration with him or talk to him about maybe trying to integrate what he's doing with brain volumetrics, and seeing if we can somehow tie in how variable morphometry. But you're right. I mean, it really is brain development. My concern is that if the cranial sutures fuse too early, then there's going to be another external factor which is going to potentially limit or impact brain development. But I agree with you. I mean, it's brain development. So, yeah.
Dr. Pindrik, so the extension to Dr. Iskandar's question, right, and the data that you presented earlier, how as circumferences decreases, the FOR pre and post shunt are the same. I'm wondering about the fluid mechanic of the system, right? And I'm wondering if the hypothesis of the pathophys is not necessarily because of ventricular volume is decreasing, or it's decreasing a little. What is the volume and the pressure in the drain system that's dropping? Because as you go down, the ventricular system is a series of two, and because resistance is the exponential factor in how pressure is reducing, is it because the pressure in the drain system that's decreasing brain volume and pressure onto the skull and skull growth that's limiting the growth of the skull?
I agree with you. I think you're correct. I mean, the FOR does decrease. I guess I may have not said it great, but between the two groups, the decline is similar. So there was a pretty significant, there was a pretty dramatic drop in FOR, but there was not statistically significant in the groups who developed post-shuntic acquired craniosynostosis and those who didn't. So despite the fact there was a drop in frontal occipital horn ratio, it wasn't significantly different between the two groups. But I agree with you. It's all of it. The extra-axial cerebrospinal fluid spaces, the outward pulse pressure and pulsations of the brain are blunted. I mean the amplitude. So I think it's much more than just ventricles. I think it's extra-axial cerebrospinal fluid spaces. I think it's outward pulsations of the brain as well. And that combination of like a blunted amplitude and blunted pulsations on the dura then translates into less outward expansion of the cranial bone. So I think you're right. I think it's more complicated than just the ventricles.
Thank you.
Jonathan, the success rate of cranial bone re-expansion is quite dismal.
It is.
As children get older. Which suggests potentially what you're implying, that by the time craniosynostosis sets in, it's already too late.
Yeah.
In which case, as you know, we argue in meetings, big ventricles, small ventricles, which then argues whether there's even an ideal FOR to begin with.
Yeah.
Because if you're chasing an ideal FOR, either you'll end up over-shunting or under-shunting, right? And then you'll swing the child either macrocephalic, in which case maybe, as Dr. Iskandar is implying, the brain won't develop, or you overdrain and then you have the problem that you're describing, which is secondary craniosynostosis. So I don't have an answer. I was just highlighting the problem.
The question stem. Yeah, I mean, post-shuntic acquired craniosynostosis, especially when there are multiple sutures involved, very challenging. I mean, for multiple reasons. One, the logistics of having shunt hardware in the potential operative field. Two, sometimes you have to provide shunt for the patient. And then three, what I worry about is the sustainability of that treatment, because if you have ongoing cerebrospinal fluid diversion, it's really going to be challenging to prevent subsidence of all of the cranial bones that you've outwardly expanded. It's not going to be something below to help apply some outward pressure. So basically what you're going to have is an expanded cranial vault, the gap of space, air, and then eventually fluid, and then the dura and brain, which is not going to be expanding outward because of ongoing CSF diversion. So, I mean, I think our approach would be trying to manage those patients with a shunt vision up front, programmable valve, maybe an extension device, really up front, and at the time, if you have to change their position of the shunt because of the impending craniofacial repair, maybe that would be a risk mitigating strategy. But you're right, it's incredibly challenging to treat after it's already set in. So
yeah, the most important lesson you're learning here about brain development is that it's a balance.
Yeah.
And to think that one thing is the whole thing, it's too much fluid or too much bone is completely wrong. And just like all the growth factors have to be in balance. Disease is the same as with growth and development. So I think it's going to be, first of all, very early. You have to be on top of the bone fusion before it takes place, because you're not going to catch up afterwards. That's clear. And that you have to not focus on ventricular size, but brain size. That's really the thing that we're all about.
Yeah. I think that's why collaboration with other researchers like Steve Schiff looking at brain volume could be very fruitful.
John, Raheel always asks impossible questions. So, but it's absolutely correct in that. Remember two things. One, if you shunt in the first year of life, something happens to the brain if you're on the side, and the skull gets small. But then you're continuing to over-shunt for 20 years.
Oh, yeah. Oh, yeah.
So that is not going to be reflected in the skull.
Yeah.
So we just have to understand what's happening with the brain.
And the lesson from the VA shunts is that once you set that up with the smaller skull and the fuse, you have no give or tolerance. The normal child has give until age 18. They really ossify the sutures. That child doesn't, so the shunt failures are more dramatic.
And they lose brain compliance. And
yeah. Cool. So it's challenging. but it's making us think far beyond what is simplistic view. Thank you.
Thank you very much. I appreciate it.